Thank you so much for joining us today. We're just going to give everybody a minute or two to come in to the webinar room. It's now my pleasure to introduce Dr. Michael Kaess. Dr. Kaess is a professor of child and adolescent psychiatry at the University of Bern and serves as the director of the University Hospital for Child and Adolescent Psychiatry and Psychotherapy in Bern, Switzerland. He is a leading researcher in the field of adolescent risk-taking and self-harming behaviors, with a strong focus on the early detection and intervention of underlying mental health conditions, including affective disorders and borderline personality disorder. His research spans epidemiology, clinical, and neurobiological approaches, often integrating these domains to support the translation of scientific findings into clinical practice. It is now my pleasure to turn it over to Dr. Kaess.
Thank you very much, Abby, for the invitation and for that kind introduction. Hello, everyone. I'll just share my presentation and then we'll hopefully be able to start soon. Okay. So today I'm going to talk about the role of adolescent self-harm in early detection and intervention of particularly borderline personality disorder. And I have no conflict of interest, although I have a strong interest in early intervention of BPD and quite a bit of research funding from diverse research funding agencies. So when we talk about self-harm, it is important that nowadays, particularly since the release of the DSM-5, we distinguish two different forms of self-harm in our research. The one is suicide attempt, which is the self-initiated sequence of behavior by an individual who, and that's very important at the time of initiation, expects that this set of actions would lead to death. And then we have non-suicidal self-injury, which is the deliberate self-inflicted destruction of body tissue without suicidal intent, and also for purposes not socially sanctioned, so this excludes piercings or other things. So these two types of self-harm are very common, and today I'll try to give you a brief overview over my own research and the research of other researchers in the field to the following topics. I'll give a quick overview over prevalence and burden of self-harm, and then I would like to shed light on self-harm in the context of early intervention of BPD, but in several different contexts. So first of all, I would like to talk about self-harm as a potential diagnostic marker. Then I will talk about self-harm as a potential marker of risk. And finally, I'd like to talk about self-harm as a treatment target. And you will see there's quite different views on self-harm depending on how you look at it, and also probably it's differentially useful. So prevalence and burden of self-harm. Major meta-analysis conclude that we have a mean lifetime prevalence of self-harm, and that does not really rely on whether we measure non-suicidal self-injury or deliberate self-harm, which also includes suicide attempt, of 18%. It is quite interesting to think about why the prevalence of non-suicidal self-injury and the major overarching construct self-harm do not differ. And likely one of the most important reasons is that those who attempt suicide nowadays very often also engage in non-suicidal self-injury. While these data are a few years old from this meta-analysis, we also need to acknowledge that there has been quite an increase of prevalence of self-harm in the younger age groups. We see here a publication that has investigated from the year 2000 until the year 2014, but we also have several research findings that suggest a further increase, particularly since the COVID pandemic. And very important, as you can see here in this graph here, the major change or increase in prevalence of self-harm can be found in the young people, and it can be found much more pronounced in the female population compared to the male population. We also experienced this increase of self-harm in our own department and in the number of help-seeking adolescents that are mostly driven by self-harm and suicidal behavior. So as what you can see here is the development of our inpatient admissions due to self-harm or acute suicide risk in the last 6 years. And that's actually quite interesting. You can see a rather stable, and low number of inpatient emergencies in 2019 and the first half of 2020. But then you can already see the effects of the pandemic and the following youth mental health crisis, which finally lead to this 3- to 4-fold increase of inpatient emergencies in our Department of Child and Adolescent Psychiatry. So nonetheless, and although this might have improved a little bit, there is still a reluctancy of seeking help in most young individuals who self-harm. So this is older data from a European-wide project that investigated the prevalence of professional help seeking in self-harming youth across a variety of countries. But we have also just recent data from Germany and Switzerland, where we have investigated large population-based cohorts, and still the prevalence of professional or the frequency of professional help seeking is below 25%, even for those who attempted suicide. So even for those youth who recently attempted suicide, we still have 75% who do not seek professional help, which obviously makes a major case for more efforts to improve early detection and intervention. And even those who finally seek professional help do this with a huge delay. So this is an own study where we investigated teenagers who finally received professional help for suicidal thoughts, non-suicidal self-injury, or suicide attempts. And as you can see here in the graph, the average help-seeking delay from the occurrence of their first suicidal thoughts, self-injury, or suicide attempt, and the first professional health contact for this behavior. And this lies at around 1 year for suicide attempts and almost 2 years for first suicidal thoughts. What we also know is that self-harm is very, very common among adolescents and youth, but there's also a normative decline in self-harm across age. So probably regardless of treatment, most individuals will stop self-harming at one point in their life, most of them in late adolescence and young adulthood, and some of them later in more increased adulthood. I'm now trying to go through the different topics of the role of self-harm in early detection and intervention of borderline personality disorder. First of all, the question whether self-harm is an appropriate diagnostic marker for BPD. Well, of course, self-harm is a symptom of BPD, and there is a close relationship between self-harm and personality disorder. But nonetheless, it's also important to note, and this view differs largely from what we thought 20 years ago, that self-harm is a broad phenomenon across a broad diagnostic spectrum. You can here see own data from a large European population-based study that clearly shows that those with depression have a hugely increased prevalence of self-harm, but also those with anxiety disorders, those with conduct problems, those with hyperactivity problems, and those with social problems. Well, that does not tell us a lot about borderline personality disorder, because we obviously know that borderline personality disorders can quite well go along with all these different comorbid disorders or mental health problems. Nonetheless, if we have a look at the comorbidity of non-suicidal self-injury in clinical adolescents, this is data from our own department from 450 adolescents who we treated in our own department, we'll see that almost all individuals with non-suicidal self-injury suffer from any kind of comorbid disorder. But we also see that it's only around 50% who suffer from a personality disorder, around 40% from BPD, and many other patients suffer from other disorders, with the majority having a mood or affective disorder. This is more than 70%. So there is nowadays a huge question mark on the specificity of self-harm as a predictor or diagnostic marker for BPD. And we have investigated that a little bit further. First, in a population-based sample, where we followed adolescents with two different aspects of self-harm or potentially risk-taking behavior, self-injury and alcohol misuse, and looked whether their burden and also their cause of self-injury or alcohol misuse would predict BPD traits in late adolescence. And yes, indeed, as you can see here, the occurrence of self-injury in early adolescence predicted the number of BPD traits in late adolescence, and so did the prevalence of alcohol misuse. And the course of self-injurious behavior, so whether we had onset, termination, or maintenance, had a small influence on the effect, but there was not a significant difference. So the sole occurrence of self-injury was a significant predictor in the normal population. However, if we have a look at clinical populations, the picture is a little bit different. Yeah? In the normal population, these kind of investigations often just simply distinguish healthy individuals from mentally ill individuals, whereas if we go to a highly mentally disordered clinical population, we have more, or we need to have more specific predictors for BPD. And as you have already heard, like my main topic is not only self-harm, but actually self-harm and risk-taking behavior. So in this study, we assessed a broad set of self-harm and risk-taking behavior, including truancy, excessive media consumption, alcohol misuse, drug misuse, smoking, sexual risk-taking, and then self-harm as regards of non-suicidal self-injury and suicide attempts. And we did a class analysis to, reduce complexity a little bit and have a look at, whether there were several or different groups of patients who would engage in different, patterns of risk-taking and self-harm behavior. So the best fit to the data was a two-class solution, which you can see here. And you can see that we actually had a red class, which high levels of non-suicidal self-injury and high levels of excessive media consumption, also quite comparable levels of suicide attempts compared to class 2, but very low truancy, low drug consumption, low sexual risk-taking, and also comparably low alcohol misuse and smoking. And this class was not at all predictive of BPD. It was quite predictive of affective disorder. Yeah. The other class, however, had high levels of self-harm in both NSSI and suicide attempts, but also had high comorbid sexual risk-taking, smoking habits, drug consumption, alcohol consumption, truancy, and this class was predictive for borderline personality disorder. So what's the take-home message here? The take-home message is that self-harm itself is not a very good, and in particular, not a very specific predictor for borderline personality disorder. However, if self-harm goes along with other patterns of risk-taking behavior, as we also find that in the criteria for BPD, then the likelihood of having a BPD diagnosis is a lot higher. So when we have a look at self-harm, we are not only interested in self-harm as a diagnostic marker, but there's been a lot of efforts to investigate self-harm as a potential marker of risk. In particular, we are talking about suicide risk here, And on a population-based level, we know that self-harm is associated with increased risk for mortality. This is a study from a big UK cohort, and they investigated individuals who self-harmed during their adolescence and were seen in an emergency room at least once for NSSI or suicidal behavior, and a large comparison cohort also from the UK health system. And then they calculated the increased risks for early mortality up to the age of around 35 to 40. And they found that there was a significantly and highly increased risk of mortality, which was particularly pronounced for suicide. You see here a 17-fold increased risk for suicide, and even more pronounced for acute alcohol and drug poisoning, so death by acute alcohol and drug poisoning. So this gives us, the bigger picture that, yes, independent probably of diagnosis, being a self-harming teenager increases your likelihood of suffering from later risk to die by suicide or acute alcohol or drug poisoning. And we also know that within the spectrum of self-harm, non-suicidal self-injury is increasing the risk of suicide attempt. One of the major theories that currently try to explain the specific factors that drive people into a suicide attempt, as an example that I want to provide here, is the interpersonal theory of suicide. The interpersonal of suicide sees two factors as main and more or less specific factors that drive suicidal thoughts. So beyond mental disorders and negative affect, they see thwarted belongingness and perceived burdensomeness as very important factors that, make people to think about suicide and wishing to be dead. But then this theory also postulates that to turn from thoughts to action, like to finally be able to attempt suicide, you need to acquire the capability to suicide. And, with this theory, I would like to, give you a few research findings that elaborate on the risk for self-harm and how the risk for non-suicidal self-injury and suicide attempts are related. So let's start with the idea of thwarted belongingness and perceived burdensomeness and how this is related with self-harm. So I'm not going to present you findings that have specifically investigated those constructs, but I'd rather like to show you a few findings on a phenomenon that I've become very interested in the last 10 to 15 years due to its, in my opinion, major role in youth self-harm, and this is bullying. So one of the first studies that we conducted on self-harm and bullying was not a specific bullying study, but it was a prospective study where we had a look at stressful life events in, almost 2,000 population-based adolescents, and whether we would find stressful life events that predict the onset of non-suicidal self-injury. So this is very relevant because a lot of research we have conducted to date, is done in teenagers who already self-harm. But if we talk about early intervention or maybe even prevention, we need to understand what happens before individuals even start self-harming. And what we found here in this list of many, many, many different stressful life events that statistically overall clearly predicted the onset of NSSI was that interpersonal relationship troubles were the most significant and important predictors for the onset of self-injury. And among these interpersonal troubles, we found that trouble with bullies, so bullying victimization, was more important than trouble within the parent-child relationship, which was one of the constructs that was and today still is one of the best evaluated risk factors. So this brought us into, the position of doing more research on bullying, and I'm not going to show you all the findings today, but just wanted to state that, bullying today is one of the best investigated and strongest risk factors of adolescent suicide attempts and adolescent suicide. And it's probably also one of the risk factors that is associated strongly with the development of BPD criteria. When we think about BPD, we talk a lot about childhood trauma and childhood adversity. And we usually mean that they either had bad childhood in their upbringing period and with their parents or their family, or that they had some external traumas or maybe sexual victimization going on. But we often tend to neglect that peer victimization is, in my opinion, a potential and very important risk factor also for the development of personality disorder. As you can see here in this clinical study, we clearly find a strong association of borderline personality criteria, even within clinical populations who generally report a lot of bullying experiences anyway. And if we do the same with the new construct, which you're certainly aware of, so the alternative model of personality disorders, we also find that personality disorder in itself, and in particular also identity, but also empathy and intimacy, are strongly influenced by bullying experience, with the strongest influence of threatening as a method of bullying and social bullying, which means that this is usually social exclusion. And that's quite interesting, given that we today know that threat hypersensitivity and social exclusion hypersensitivity are factors that we find in individuals with borderline personality disorder. So I'm just sometimes wondering whether there is a strong relationship about what people with BPD experience, in particular also with regards to their peer group, and what kind of personality patterns they develop during their life. So if we go further in this interpersonal theory of suicide, we come to the construct of acquired capability to suicide. And the acquired capability to suicide is an interesting phenomenon because it really suggests that, as human beings, we have this natural barrier to harm ourselves. Although we might think that we would prefer to be dead, and although, we might have suicidal thoughts, most of us, and indeed most youth with suicidal thoughts, would not turn their thoughts into actions due to a natural hesitation to harm themselves. However, you can reduce your threshold to harm yourself, and you can reduce your natural barriers to harm yourself and to finally turn your suicidal thoughts into actions. And one of the ways to reduce this barrier is repetitive non-suicidal self-injury. Another barrier, for example, is substance use or alcohol misuse, which also reduces the barrier to, turn your thoughts into actions. And there's quite a bit of research nowadays that suggests that there's something quite true about this idea. One of the well-replicated research findings, for example, shows that individuals who harm or who self-harm repetitively have a quite strongly reduced pain sensitivity. This is a meta-analysis that we conducted in 2016. By now, we have even done longitudinal studies that show that it's really the repetition over time that goes along with decreased pain sensitivity. And it is quite likely that individuals who do not experience pain and have reduced pain sensitivity have a lower threshold and have lower barriers to harm themselves again and maybe also commit suicide at one point. And if we have a look at individuals with self-harm and how NSSI in terms of timing relates to suicidal behavior, we clearly see that NSSI often occurs in a similar time frame as the onset of suicidal ideation. Yeah, you see here time of onset of NSSI. This is a longitudinal study of adolescent patients, goes along with an increase and peak of suicidal ideation. But what you also see is that in the same teenagers, the suicide attempt is usually occurs with a delay of 1 to 3 years. And in large longitudinal population, we have also found quite clear evidence about the effect of self-injury as a moderator between suicidal ideation and suicide attempt. So obviously suicidal ideation increases the risk for suicide attempt, but this effect is even moderated by self-injury. So if you are self-injuring and you have suicidal ideation, you are much more likely to do a suicide attempt. And if you have a look at adolescent population in the longitudinal approach, you find something that is interesting but also quite encouraging, because it seems that the capability to suicide may be something that is potentially reversible. So in this study, we have followed around 500 individuals from early to late adolescence. And you can see here 4 different groups based on their cause of non-suicidal self-injury. Those who never self-injured, those who started in middle to late adolescence. There are many adolescents who showed remission of self-injury. So they self-harmed in early adolescence, but then they stopped. And the 10% who showed consistent self-injury over time. And here you see the risk for suicide attempts. And it becomes very clear that the onset is associated with an increased risk of suicide attempt and, of course, the maintenance of self-injury. But those who remit in non-suicidal self-injury, they also have a reduced risk for suicide attempt. And we'll get to that later when we talk about the clinical relevance. So let's now move to self-harm as a treatment target. In 2013, I was in Heidelberg in Germany. We already had so many self-harming teenagers, many with BPD features, many with depression, also quite a few with full-blown BPD. And we had one of the first DBTA programs in Europe, but we had so little resources that we were not able to, offer a majority of those help-seeking patients DBTA. So what we did together with colleagues from the King's College, we developed and adapted some kind of mini CBT and DBTA, which is called the Cutting Down program. And the idea was really to have a short program with 8 to 12 sessions, which could also be, it was highly manualized, or it is highly manualized. It could be conducted by trainee psychotherapists. It basically consists of some kind of psychoeducation and commitment building, then behavior and functional analysis, skills training, and integration into all-day life. And we tested this in a randomized controlled trial compared to a high-quality treatment as usual. So if I talk about high-quality treatment as usual, why do I state it's high quality? Well, often if we compare a psychotherapy approach with treatment as usual, that means that treatment as usual is some kind of waiting list or a very loose psychiatric management. But in this case, we made sure that after baseline and randomization, participants were either allocated to our trainees conducting 10 sessions of Cutting Down program, or to fully trained psychotherapists who did 25 sessions of regular psychotherapy with these patients. So the treatment as usual group had psychotherapists with better training status and almost the double dose of psychotherapy delivered. We then did a post-line assessment after the Cutting Down program, which was 3 to 4 months, and it was obviously in the midst of treatment of the treatment as usual due to the higher frequency of treatment sessions. And then we had a 1-year follow-up. We randomized 74 adolescents who all completed the trial. I need to admit I had fantastic PhD student who was so good in recruiting, but also maintaining the relationship with all the patients. And this was the result that we found. For the Cutting Down program, we had a significantly steeper and stronger decrease of non-suicidal self-injury within the first 4 months of treatment. And that is the important message, no increase of self-harm, although we had a treatment-free period during these 6 months. So they did not get any further treatment. For the treatment as usual, the outcome was not too bad. So they had a significant reduction of NSSI, and at the 1-year follow-up, they ended up almost similar to the Cutting Down group. It just took them the double dose, much more trained psychotherapist, and quite a longer time. So we concluded that the Cutting Down program is actually an efficient first step approach in early intervention for self-harming adolescents. But we were still some kind of unsure whether we could really do that in early intervention for borderline personality disorder, in particular with those who already suffered from full syndrome BPD. The interesting thing, however, was that already in this briefer follow-up, we found that those with BPD had exactly similar effects in the Cutting Down program than those without BPD. So individuals with BPD did not benefit from the longer treatment with more experienced psychotherapists. And then we conducted a 2- and a 4-year follow-up, and we still found no group differences between the 3 groups, with a non-significant but even trend effect for reduced suicide attempts in the Cutting Down program. And even more important, in the Cutting Down program, after 2 to 4 years, we found that significantly more individuals achieved a remission of BPD compared to the Tau group. So what I'm not telling you here is that 10 sessions of the Cutting Down group is sufficient to bring BPD, to treat or cure BPD. Many of those patients in both groups, Cutting Down and treatment as usual, had further treatment, and further treatment sessions were associated with improved outcome. I actually think that the advantage of the Cutting Down program is that it provides an easy, accessible, low threshold access to care that brings some improvements and some relief to the patients very early. And my opinion is that it can give particularly young patients with self-harm and emerging BPD a good first experience with the mental health care system. And that is urgently needed if you want to do appropriate early intervention. So the next step that we are currently trying is to, or that we have tried, is to develop an online version of the Cutting Down program, which we investigated within a large multi-center trial. The trial is called STAR and the program STAR Online. This time we tried to investigate STAR Online, which has a lot of fully automated components from the Cutting Down program and some chat-based counseling. And we compared that to online psychoeducation. You see here a few things. You see also that for the interim results, we had not reached our final sample size, which was 512, and here we were at 370. But what you can see is that graphically, I have not done statistical analysis at this stage because the trial was not finished. Graphically, it looks quite good, and it seems that the STAR online program is well capable to reduce self-harm, while the control group, the psychoeducation group, is not. I can also tell you that by now we have finished the randomized control trial, and I've done first preliminary analysis, and the results hold, and they also hold statistically. So we are now also able to reduce self-harm with a very low threshold online CBT, mini DBT program, an online version of the Cutting Down program. And I'm again not saying that this is able to cure BPD, but given that we have so many individuals who end up on waiting lists or with no care, even they present with risk-taking and self-harm behavior, I guess low-cost online intervention is certainly better than doing nothing. So in the end, I would like to show you a few data on the question of the divergent causes of self-harm during early intervention of BPD. So this is all data from our at-risk cohort. Some of you might know at risk, it's an acronym for the German word of Ambulanz für Risikoverhalten und Selbstschädigung, which means outpatient department for risk-taking and self-harm. But it's a quite rigorous early intervention service for BPD that takes individuals from the age of 12 up to the age of 18 years. And so when we follow up those individuals in our cohort longitudinally, it's quite a few hundred individuals by now. We see that we have a strong decline of self-harm, and particularly non-suicidal self-injury within our cohort. Yeah, as a mean effect, that looks fantastic. It really looks like, oh, we are gonna help them all. It's a very nice line and a huge effect size. But I also want to go into a more in-depth and critical view on what we actually achieve, because what you see here is the individual trajectories of the different patients in at risk. And what we see here is, yes, the outcome is not bad. For 75% of our patients, we achieve a treatment response, which we defined as a reduction of more than 50% of NSSI frequency. However, most parents and patients, they don't come into our service and say, oh, can you please make that my child reduces self-harm? They actually say, please make it stop. And if we think about making it stop, we end up with our remission rates after 1 year, and our remission rates are not looking that well anymore. It's only 25% of our whole cohort. And if we then had a look at the relapse rates even 1 year further, we see that out of this 25%, only a little bit more than half show continuous remission and quite a few start self-harming again. Not to talk about the 25% of non-response or even exacerbation during treatment. Interestingly, if we have a look on what predicts treatment non-response and non-remission, it's the severity of depression and not the severity of borderline personality disorder. So our program seems to target BPD and BPD features very well, but somehow the severity of depression has an influence that we have not been able to target sufficiently. And what we always find is that those teenagers that need to enter inpatient treatment, and that is already adjusted for all the different confounders, including symptom severity, suicidality, and many other environmental factors, still have a poorer outcome. So we still think that inpatient treatment is probably not the right thing to do in adolescents with BPD. One of the big questions, if we talk about self-harm as a treatment target, is always, does a reduction of self-harm mean that individuals have a favorable treatment outcome also with regard to BPD? Because in particular in child and adolescent psychiatry, we often look at self-harm as, oh yeah, if the individual stops self-harming, that's fantastic, then we are on a good track. But is that always true? So what we have done here is we have done a class analysis of the co-occurrence of substance use and non-suicidal self-injury within our treatment cohort. And what we see here is that there is my favorite class 1, but this is only 12% of the individuals. They show a steep decline of self-injury, and that goes along with a steep decline of substance use. So fantastic. Risk-taking goes down, self-harm goes down. Really good. The largest class, however, the class 2, is still looking okay, but not that great. They have a significant decline of self-injury and a slight increase of substance use. Well, we see that as an age effect. You know, if our cohort is 12 to 17 years of age, within 2 years, there's a normative increase in substance use. So it's still a cohort that benefits from our treatment. But then we have this bloody class 3, still with a reduction of self-harm, a significant one, but at the same time, a strong increase of substance use. And this is what we call the symptom shifters. You know, there is quite a few patients who will reduce or maybe even stop self-injuring, but who will engage in severe alcohol and substance use as a kind of replacement behavior. And not very surprisingly, in these two classes, we find a reduction of BPD traits during the course of treatment. And in this class, we find no reduction or even an increase in BPD during treatment. So there is a non-response group, and that cannot always be seen by a non-decline in self-harm, but maybe by symptom shifting to other emotion regulation behaviors. But what we see is that if we are able to reduce self-harm or even have a remission of self-injury, we have a significantly and strongly reduced risk for suicide attempts. So what I've shown you previously in the population-based cohort is exactly mapped in the clinical cohorts. The reduction of NSSI is a very good predictor of the reduction of suicide risk. And at the same time, the reduction of NSSI in our cohort is not a predictor of the reduction of BPD symptoms, not a predictor of the reduction of depressive symptoms, and not a predictor of improvement in psychosocial functioning. So in the end, yes, self-harm is probably a valid treatment target. I mean, there's a value in stopping self-harm for the sake of just stopping self-harm. And it's also important in terms of reducing suicide risk, but it's not a very reliable predictor to see whether we are also capable to reduce borderline personality disorder. My take-home message today is, I guess that was something that you already knew. Self-harm is very common among adolescents, in particularly in our clinical settings. So today, we see self-harm as a transdiagnostic marker of psychopathological burden and, in particular, increased suicide risk. There's a lot of evidence that self-harm and even non-suicidal self-injury is a good marker of increased suicide risk. Self-harm, however, is not a specific marker for BPD development. It may, however, well related to shared risk factors. I've shown you bullying today, but there are several other risk factors that borderline personality disorder certainly shares with the general occurrence of self-harm. Self-harm can be successfully targeted by brief psychotherapeutic interventions, likely even delivered online. And non-response and non-remission of self-harm, however, remain a common problem at an individual level. Yeah? Although we find a lot of evidence that there is a good benefit of our interventions, we still have far too many individuals who will not sufficiently benefit from what we can offer them today. And it's also very important to understand that in early intervention, while reduction of self-harm may clearly indicate reduced suicide risk, caution is warranted when assuming general treatment success on the basis of reduced self-harm behavior. At the end, I always want to clearly state that research cannot be done alone. I'm very lucky to have a great research team with a lot of people who are supporting me, collaborating with me, and working with and for me. And I thank you very much for your attention, and I'm very happy to answer any questions if there are some. Thank you very much.
Thank you so much. We do have some questions, and I'm going to remind everyone in the audience, if you do have questions, please feel free to put them in the Q&A. So we have a question here. Are there more consistent types of NSSI across adolescent props, example, cutting, burning, or even gender differences that you see most often?
Yes, there are very pronounced gender differences. Like the most common form or type of NSSI is cutting, but it's a quite predominantly female type of non-suicidal self-injury. Now we see that very commonly in female adolescents, while male adolescents, if they engage in non-suicidal self-injury, more likely engage in self-hitting or self-burning. Yeah, for example, with cigarettes or things like that. So that's the most pronounced gender differences.
Thank you. We also have a couple of questions about the Cutting Down program. People are wondering if it's available for practitioners who are looking for effective interventions. We have another question similar. Is the curriculum in your program available to share?
Yeah, there's a little bit of a yes. So the German version is freely available because I just give them to people. The problem is that there is an English version which was then further developed by the King's College, but that was given to a publisher and is available, but it's not exactly the same version that we evaluated, and it is available, but it needs to be paid by a publisher. And I just, I'm brave enough to just distribute my German version, but I'm not brave enough to translate this into English while the copyright is with an English publisher. That might end up with some kind of, law issues for myself.
Right. No, we understand.
But there is a cutting down manual in English. So if you want to look in the internet, you find it with the publisher that has published it.
Perfect. Thank you. we have a question that is not particular to self-harm, but is definitely, for early detection and intervention. So the question is, can you diagnose under 18?
Oh
A
yeah,
person?
yeah. Most there's like there has been many very rigorous meta-analysis and systematic reviews also for many international guidelines, NICE guidelines, also the German-speaking AWMF guidelines, the Australian NHMRC guidelines, and they all concluded that there's clear evidence that BPD can reliably be diagnosed from the age of 12 years on. Um, there is some, adaptations that the pattern of BPD symptoms is a little bit different. Young people usually show more of the acute behavioral symptoms and a little bit less of the more stable symptoms, such as, identity disturbances and these kind of things, who are, often more stable across the lifespan. But it can reliably be diagnosed, and it should also be diagnosed because we, diagnosing BPD or BPD features, may ideally result in disorder-specific interventions and a particular pattern of care that is then really helpful for those adolescents. But I know that there's still, kind of a lot of people who, who haven't heard that or who still feel that personality disorder is something that needs a mature personality. But it's really clear. Let me say you a few words around this. So there is no such thing as a mature personality. We know that personality changes across the lifespan all the time, and that makes sense. We need to adapt to different situations and phases of our life. And there's clear evidence that, for example, personality changes between the age 20 and 30 are often more pronounced than between the age 10 to 18. Yeah. And the other, so there's no such thing than mature personality. It's always fluent. And there's also no such thing than stable personality disorder. Personality disorder is not stable. We have normative declines of personality disorder from the age of young adulthood on. Yeah, and we have a lot of multifinality in BPD. So I think we should regard BPD as a diagnostic construct that is not so different from other disorders that can occur, and they can be persistent, but they can also be transient. And the most important message, they are treatable.
Very important. Thank you. I know it wasn't directly on topic, but such an important question to answer. We have another question here. Do you think that access to AI by teens will increase the rate of non-suicidal self-injury?
To AI. Well, I'm not sure if I would really be already in the position to predict what AI does with us. What we quite certainly know is that social media is able to trigger NSSI and probably also plays a role in the worldwide increasing prevalence of self-harm, because similar to what we know from suicide for a long time with the Werther effect, also self-harm and non-suicidal self-injury underlies social contagion effects. We have social contagion in non-suicidal self-injury, and social contagion works fantastically and quickly over social media.
So I have one more question here. If a person who has BPD has stopped the non-suicidal self-injury, does this show that they're on a positive journey to recovery?
Well, that's what I tried to say. It's a good question to sum up one of the key messages on my talk, because I would say, well, yes and no. Yeah. Yes, because I would always say also in DBT terms, well, fantastic. You have been able to stop your non-suicidal self-injury. What a great job. I mean, that in itself is a treatment success, full stop. We can probably from our research also conclude that this reduction or even remission of NSSI is likely associated with a clearly decreased suicide risk. And that's fantastic. That's a clear treatment success. However, we cannot necessarily conclude that those individuals suffer from less borderline personality disorder or less depression, or that they even already been able to increase their psychosocial functioning. Yeah. So NSSI is a sensitive marker for suicide risk, but it's not such a sensitive marker for psychopathology or even psychosocial functioning. And I would suggest to clearly have a look at whether they also show improvements in other BPD criteria and whether they show improvements in psychosocial functioning, and to be aware of potential symptom shifts. So there is this not huge but small subpopulation that decreases NSSI but replaces self-harm behavior by severe substance use or other risk-taking behaviors. And that's obviously something that is prognostically not very good.
That we just shared. And we thank everybody for joining us today. And Dr. Kaess, a huge thank you to you. We have a ton of thanks in the chat here. So we appreciate your time and for sharing all of your knowledge with us.